Hi everyone, I want to talk about the possible complications of diabetes mellitus. Actually, there are two broad categories. It's either the microvascular or the macrovascular complications. For this moment, I'm going to talk about microvascular complications. Okay, let's go. Among the possible microvascular complications of diabetes mellitus is retinopathy. And diabetic retinopathy is the leading cause of blindness in diabetic mellitus patients. It's the commonest cause of blindness in North America, probably because they keep records, because it's likely going to be the same all over the world. Clinical features of diabetic retinopathy is going to be big on ophthalmoscope. Of course, that's obvious. And there's no need to waste any time. We just refer to ophthalmologists. Diabetic will also be complicated by cataract, but that is lens opacity and it is non-vascular. Another microvascular complication is nephropathy. Diabetic nephropathy is the common cause of renal failure. And to make that diagnosis, we're going to do albumin to creatinine ratio immediately, and we'll repeat every 1 year in type 2. Intensive investigations as per diabetic nephropathy will start after 5 years of diagnosis in type 1. But it's going to start immediately if this is type 2, and we're going to repeat that every year. To prevent further damage to the nephrons, we're going to stop all nephrotoxic medications like aminoglycosides of all sorts. Then we're going to use cardio-Renal protective medications like angiotensin converting enzyme inhibitors. And if the individual is having a kind of reaction to that or cannot tolerate it, we can use angiotensin receptor blockers. In other words, if you can't use rabiprazole or captopril, then you can use any of the statins. Even if there's no hypertension, that doesn't stop you from using angiotensin converting enzyme inhibitor. As a matter of fact, it's part of the treatment right now for diabetes mellitus. The only thing that we're going to take cognizance of is the blood pressure, because it must not be too low. Therefore, we have to keep the blood pressure to be between 130 and over 80 millimeters of mercury. Neuropathy. This is a lot of trouble for a lot of people that have diabetes mellitus. The culprits here when it comes to neuropathy secondary to diabetes mellitus is rise in the level of sorbitol or decreased level of myoinositol and excess advanced glycation end products. In other words, lipids and proteins that have become glycated after exposure to glucose, the value of them or the number of them will be more, and that is a big problem. Of course, oxidative processes and protein kinase C, and also nerve growth factor reduction. How will neuropathy present? Okay, there's possibility of paresthesia. The individual will be complaining that, oh, I'm having tingling or itching, and of course, neuropathic pain, on account of which the affected individual could be, seeking doctor or shopping doctors all around just looking for narcotics of any sort. and there's possibility of localized pain in form of radiculopathy, numbness, and decreased sensation, and carpal tunnel syndrome. There's possibility of ulcers, particularly foot neuropathic ulcers, and Bell's palsy. We are going to carry out examination to know there's neuropathy or not, mostly through diabetic mellitus foot examination. That will involve general physical examination for peripheral vascular disease and as well as neuro. The neuro will involve sensory, having a light touch, sharp and dull, pain, and so on. And you can also test for proprioception and using tuning fork for vibration. Monofilament is designed for this purpose. There's also the possibility of diabetic mellitus amyotrophy, where the individual will present with pain, weakness, wasting of hip flexors and extensors. Now, autonomic complications will present in form of alternate constipation and nocturnal diarrhea. Let me repeat. Autonomic complications of diabetes mellitus will present with alternate constipation and nocturnal diarrhea, and that in men will present with erectile dysfunction. Erectile dysfunction is a big problem for many people, particularly the younger or the middle-aged men with diabetes mellitus. That is going to be a separate topic for another day. And there's possibility of urinary retention and high heart rate and postural hypotension, all due to autonomic dysregulation. How do we treat neuropathic complications of diabetes mellitus? Instead of doing doctor shopping, looking for narcotics all around, when an appropriate diagnosis is made, we use tricyclic antidepressant or Cymbalta or duloxetine. You can use anticonvulsant like tegretol or carbamazepine, particularly because it's very useful in handling pain. As a matter of fact, carbamazepine was actually manufactured for hepatic neuralgia, and we can use Neurontin or Lyrica and Votrient cream or capsaicin. We should address erectile dysfunction in men that are still active with the aid of Cialis, Viagra, or Levitra, but we need to check the BP before doing that and make sure the person is not on any other medication that could shut the blood pressure down, or else the individual will be dead. We can choose erythromycin to treat long-standing diabetic mellitus patients if you suspect autonomic neuropathy, because it increases gastric emptying if the individual is constipated. But what about the other side of autonomic dysregulation? If it's not constipation, what if it is diarrhea? In that case, you treat appropriately. Okay, with this, I've come to the end of this presentation, and I'm going to present another one on microvascular complications. Kindly subscribe to my channel so that you can get these presentations immediately they are published. Thank you.